November night. But my name's Oscar, and tonight I'm going to be talking about AKI for finals. I've tailored it quite a lot towards what I think is important to know for finals. So hopefully this is going up on YouTube as well, so people will be able to review it before their exams, towards the summer. But it's going to be it's going to be case-based with some MCQs really to highlight key points. And then also I've put some exam style questions at the end. Specifically, we're going to talk about defining AKI, some of the causes of AKI, the management, some of the complications of AKI, particularly hyperkalemia, because it's quite an important one. And also I've got a star up in the top right corner. So if you see that on a slide, those are the things that I think are important for finals. So reason I chose to speak about AKI really is it's quite a common thing especially in acutely unwell patients and patients admitted to ITU. And as a junior doctor, it's something that you'll have to deal with. So it's kind of good to have a rough idea of what you're going to do management wise, and also, how you're going to deal with some people who might actually be quite unwell. So here's the case. I'll let people have a little read just for a second. So it's Mrs. Jones. She's 72. She's presenting with confusion. She's got a history of type 2 diabetes, hypertension, and osteoarthritis. She lives in a care home, and carers have noticed that she hasn't been to the toilet and she's been shaking. The medications are shown there, and then if vital signs are at the bottom. So blood pressure 85/60, heart rate raised to 110, and she's got a temperature. So just have a little think about if you're worried or not about Mrs. Jones, and maybe if you've got a few differential diagnoses in your head. And then there's an MCQ coming up now. Catherine, are we going to pop it up then? Or can we pop it up on the Zoom function? There we go. So we'll see if you want to have a go. So what's the most appropriate course of action for the junior doctor reviewing Mrs. Jones? Perform an A2E assessment, give oxygen and prescribe antibiotics, give 500 milliliters of IV fluids, take a VBG and perform blood cultures and insert a catheter or measure urine output.
Any guesses?
We'll end that there, Catherine, I think.
Sure.
What we'll do is instead of us bringing up the poll function, we'll just talk about them instead, and I'll pause for the video so that people have time to have a think.
Good.
Okay. So for this one, the most appropriate course of action is to perform. Oh, my mouse isn't working. To perform an A2E assessment. Okay. So what I was trying to get at with this case is Miss Jones is acutely unwell. She got quite a low blood pressure. She got a temperature, and she's looking quite unwell. So the most appropriate thing to do would be to perform an A2E assessment. Whilst B, C, D, and E would all be correct, actually, because if we think she's got sepsis, which is what I was getting at, then those are all the sepsis 6. However, actually performing an A2E assessment would allow you to do all of them, dealing with the most important problems first. So for finals wise, I think knowing about the sepsis 6 is quite important. So give 3, take 3. That's something that you really need to know. And then just if you're ever faced with an acutely unwell patient, perform an A2E assessment should be your first answer. Similarly with if you're managing a cancer, MDT approach, these are kind of buzzwords. And whilst you might not get an exam question like this, they may give you questions where all the answers are actually right, but it's which one's the best answer. And by performing an A2E assessment, you could do all of the other answers. So moving on, here's some of Mrs. Jones's investigations. I'll highlight the key ones. So she got a raised white cell count, she got a raised CRP and lactate. Creatinine's 130, previously was 86, and urea's raised at 8.5. Urinalysis, again, showing an infection picture. So particularly want to focus on the creatinine, ready for the next question. So it was 86 and now 130. What stage AKI does Mrs. Jones have? I'll just pause for a second here to allow people who are rewatching this to have a think. Okay, and so it's stage 1. So creatinine was 86, then it's gone up to 130, increased from 44 from baseline. So on the next slide, I'll show you how we stage AKIs. So firstly, to diagnose or define an AKI, you need to have, it's either based on your serum creatinine or your urine output. So if your creatinine's raised by greater than 1.5 times whatever the baseline was, then you can say that this person has an AKI. Or if there's greater than 26.5 micromoles per liter increase, then you can also say that this person's got an AKI. Similarly, if the urine output's less than 0.5 milliliters per kilogram per hour for 6 to 12 hours, then you can say they've got a stage 1 AKI. So that's just basically to define AKI initially. Then you can say they're stage 2 if it's 2 to 2.9 times baseline, and the same for urine output. And then obviously going into stage 3, I'm not going to read them out, but this table's from the document shown at the bottom, and I'd say this is something that's maybe not that important to learn off by heart, but you need to have a good idea about, okay, this person's creatinine's gone up. Is it enough to say it's an AKI? Are they at risk of an AKI? And so, yeah, this table is something that I'd say is reasonably important. So MCQ number 3, which of Mrs. Jones's medications should you stop? And again, I'll just pause, or feel free to pause the recording here. Okay, so the right answer, what I said was the right answer, is E, so A, B, C. I don't know if Catherine agrees with me, but actually Mrs. Jones had a low blood pressure as well, so I think you could argue that you'd stop or at least hold her amlodipine anyway whilst her blood pressure was low. But what I was basically trying to get at in this question is Mrs. Jones' medications that she's on are all risk factors for AKI. So ACE inhibitors can cause AKI, and we'll get onto that in a minute about how and why. Metformin, again, needs to be stopped in AKI because metformin is renally cleared, and basically what would happen is you get a build-up and then you're at risk of lactic acidosis. Atoracoxib is an NSAID, just in case anyone didn't know what it was. And again, they can cause AKIs, and same as ACE inhibitors, need to be stopped. So moving on then to straight from that to nephrotoxic drugs, there is tons and tons and tons of nephrotoxic drugs. I'm going to highlight a couple of the key ones here. So NSAIDs and ACE inhibitors, we're going to talk about a bit more in a minute. Gentamicin's nephrotoxic, and it's a type of antibiotic called aminoglycoside. IV contrast that's used for CT scans, that's nephrotoxic. Chemotherapy is another big one. And honestly, there's tons and tons more, but I'd say the left-hand side of that list, or the right-hand side, is things you need to think about and know about, because they're a big cause of AKIs. So on to ACE inhibitors and NSAIDs. So this is my diagram of a glomerulus. So you got your afferent arterial and efferent arterial, blood going in through the afferent and then out through the efferent. So in a normal person, when the GFR drops, so the glomerular filtration rate, you get afferent vasodilation to get more blood going over it, and the efferent vasoconstricts, so it spends longer over it, and then you get an increase in your eGFR. So the way ACE inhibitors and NSAIDs cause AKI is basically the NSAIDs end up blocking prostaglandin synthesis, which then leads to impaired afferent vasodilation. So your afferent arteriole can't vasodilate. Then your efferent arteriole is to do with the ACE inhibitors. So they obviously mean that less angiotensin II is made. And basically what happens is you don't get vasoconstriction at the efferent arteriole. So this is how ACE inhibitors and NSAIDs cause your AKI. So it's a bit of back to basics really about how they cause it. This slide just threw in just because it's important to sometimes think about some of the risk factors. So age is always a great risk factor. If you're stuck for one in an OSCE or something, you know, age and smoking are always really good risk factors to come up with for almost any disease. Diabetes, pre-existing CKD, volume depletion, hypovolemia, sepsis, and some other conditions listed there. It's quite nice to think about these then in the context of actually causes of AKI, which we'll come on to in a minute, because they are the causes really for some of them. So next we're going to talk about the causes of AKI, particularly pre-renal, renal and post-renal. So it's quite nice to categorize it into that. So if you're ever in an OSCE or in an exam, you can categorize them and think of them in a nice kind of way, so that your answer's not all over the shop. You know, it's very much like, so my pre-renal causes or my differentials are pre-renal causes such as sepsis. So basically pre-renal is all to do with perfusion of the kidneys. So basically anything that kind of stops the kidneys getting blood. So whether that be like a low blood pressure due to like dehydration or sepsis. And then we just spoke about the ACE inhibitors and NSAIDs, so how they stop blood flow to the kidneys. Particularly in sepsis, you get like basically third spacing due to all the cytokines that are released, and then that's why you have a low blood pressure. So quite straightforward to think of these, and it's kind of a reversible cause, because if you give them IV fluids and get their blood pressure up, or if in heart failure you give them some furosemide and stop the fluid overload, actually they'll start perfusing the kidneys again, and it'll be and they'll basically recover. So then onto the renal causes. These are a little bit more complicated, and actually some of them could have a session in themselves. Just a point on acute tubular necrosis, or ATN. So ATN would basically happen after a prolonged period of a pre-renal AKI. So if you weren't perfusing your kidney properly for a specified amount of time, I don't know how long, but let's say 24 hours, then you might start to develop a tubular necrosis of the kidney, which is basically a hypoxic injury. And at that point, then it starts to become irreversible. Some other ones in here: myeloma, tumorlysis syndrome, vascular causes, all the glomerulonephritises. They're attacking the kidney directly itself. Acute interstitial nephritis, you get that as well with lots of different drugs. And so some of the drugs are directly nephrotoxic. For example, gentamicin, it basically destroys the tubules of the kidney. So these are a little bit more tricky, but again, you don't have to learn all of them. Just have a couple that you know about, or at least think about it in terms of renal causes. So post-renal causes of AKI, again, similar to the pre-renal ones, quite easy. You just need to think of blockage. So pre-renal is perfusion of the kidneys. Post-renal is a blockage after. So in the urethra or ureters or the bladder. So again, I've listed loads there: renal stones, cancers, BPH. If you're considering a post-renal cause, then you need to get an ultrasound scan, and a bit of a buzzword for that is your ultrasound scan would show hydronephrosis of the kidneys, okay? And that's just basically the back pressure causes the basically the collecting ducts to expand, and you can see that as hydronephrosis on the ultrasound scan. So I put this slide in just to kind of highlight the fact that a lot of these AKIs, you kind of don't need to investigate that much, because for some of them you can get what it is. So for example, the first one is if someone's got diarrhea and vomiting and they're dehydrated with reduced skin turgor, the most likely cause of their AKI is going to be a pre-renal cause. You know, second one down, prescribe gentamicin straight away in your history. You need to be asking about drug history because, you know, it could be caused by a drug and be a renal AKI. 85-year-old man not passed urine for 2 days and usually gets up for frequency at nights. Again, you're thinking, has this person got BPH? And then similarly with the last one, younger lady, hematuria, fever and a rash. You know, is this a glomerulonephritis? Is this lupus nephritis causing a renal AKI? So actually in someone who you suspect to have an AKI, the history is really, really important, particularly on your drug history and also your review of systems, because actually if you didn't do a good review of systems, you'd never get like some of the weird and wonderful stuff that happens with the glomerulonephritis or those kind of things. So yeah, that's just a little plug for good histories, but obviously that comes with practice. So Mrs. Jones, she's resuscitated with sodium chloride and started on IV coamoxiclab, and she's diagnosed with urosepsis caused by E. coli. Here are her U's that have come back 4 hours later. So the creatinine's now increased to 312. The urea's also increased, and her potassium is now also raised at 6.2. So she's not getting on very well, really, is she? So MCQ 4, which changes are shown here in Mrs. Jones's ECG. Just pause again if you want to pause it to have a little think and have a read of the ECG.
Oscar, we've got a few people in now. I can launch a poll if you'd like.
Oh, yeah, go on then. Give it about a minute, is it, Catherine?
Yeah, sounds about right.
Okay, thank you.
So we've got someone in the chat that's just said peak T's as their answer.
Yeah, that's right. So yeah, so again, Mrs. Jones got hyperkalemia. So peak T waves is one of the textbook, you know, things that will be in an MCQ that you just straight away got to know, yeah, that's hyperkalemia. So you can see I have highlighted here, T waves are quite pointy and tall, sometimes referred to as tall tented T waves. So they're not like a normal kind of T wave. Yeah, so rest of this ECG, I'm not going to go into too much interpreting ECGs because again, that's just a whole nother thing, but actually our ECG doesn't look particularly great. I've got another ECG, this website at the bottom as well, is quite good, loads of ECGs on there, especially if you want to practice your interpretation. Put another one up here, again, it's probably slightly worse. So again, just highlighting the tall T waves, tented T waves, and also starting widening of the QRS. You can also kind of see as well, it's starting to become a little bit of a sine wave pattern where actually the P waves, they're starting to fall in they're basically quite hard to see. And it's starting to become a bit of a sine wave, but that'll make more sense when I show the next slide. So again, I popped a star on this because this is something you really need to know, you know. These ECG changes are textbook and if they come up, you know, something, it's really easy marks to get, you know. So key points, peak T waves, prolonged PR, you start to lose the P waves then as it gets higher and the QRS complex starts to widen. You end up with what's a sine wave at the bottom, but then you can also get all sorts of different arrhythmias. So VF, asystole, bundle branch blocks, loads of weird stuff. But the main things really to focus on is peak T waves, loss of P wave, prolonged PR segment, and then widening of the QRS complex. So yeah, that is something definitely to know. I don't know if there's point of launching the poll again, or just give people a second to have a think about this question. So what's the most appropriate initial management for Mrs. Jones's hyperkalemia?
So someone said C.
Yeah. So that's right. So yeah, give 10 milliliters of 10% calcium gluconate, and I'll get onto why in a second. So this is a little algorithm that I made that I'll talk through now. So basically, if your potassium's raised, but not above 6.5, and there's no ECG changes, then it's not particularly urgent. So you might just treat the cause of it. For example, if they had a drug that they were taking that was causing a raised potassium or any of the other causes, then you might just treat that, or you can use calcium resonium, which basically binds it in the gut. But this should just point out, this is very much if it's only very much non-urgent. As soon as you get ECG changes, straight away you need to be given calcium gluconate, because basically what calcium gluconate does is it stabilizes the myocardium, which basically stops any of those worse arrhythmias happening, so basically prevents it from happening. So that's something you really need to know. So basically calcium gluconate, 10 mils of 10% over 2 minutes, and you can repeat that. Similarly for calcium chloride. So what they'll do is in a question, they'll put calcium gluconate and they'll put calcium resonium because they sound really similar, but actually it's very different the way they work. If you gave the calcium resonium to someone with ECG changes, it'll take like 2 days, 3 days to work, and it literally won't do anything. So importantly, anyone with hyperkalemia, if it's really raised or they've got ECG changes, firstly, do an ECG. Secondly, give calcium gluconate. Then you need to think about getting potassium out of the blood and into cells. So this is done in 2 ways. So insulin dextrose infusion, so 50 mils of 50% glucose. There is other regimes with 10 units of insulin. So basically what happens is the insulin causes potassium to go into the cells, and the glucose is there because if you just gave insulin on its own, you'd give someone a hypo. You can also use nebulized salbutamol, and you can do them back to back. And again, that is kind of the same kind of thinking. It drives potassium into the cells. If someone's really unwell, you can dialyze them, and again, that will restore their potassium.
Oscar, just had a brief question in the chat. Someone's asked if you could possibly explain the difference between calcium bicarbonate and when that's used.
Calcium bicarbonate? Yeah. Okay. So I don't think it's used in hyperkalemia. I'm not sure if you've heard of it being used, Catherine. Sodium bicarbonate is sometimes used in acidosis. So people with AKIs can get like a metabolic acidosis, and you can use that, but that's very much like specialist management. I've not heard of calcium carbonate, but correct me if I'm wrong.
Oh yeah, they've said so. They've corrected themselves. Sodium bicarbonate is what they were referring to.
Oh, sodium bicarbonate, right? Okay, yeah. So just I will get onto that in a sec. But basically, sodium bicarbonate is in AKIs or in renal failure, particularly, you can get a metabolic acidosis, and basically the sodium bicarbonate goes to correct that. Again, this is not something that you'd be doing as a junior doctor in A&E. This would be, the person would be on like monitoring, probably an ITU at this point. And basically that's to try and correct the acidosis, because again, if your blood's acidotic, you're basically not well. That's the simplest way to put it. So there it is there. Severe metabolic acidosis is one of the complications of an AKI, same as uremic encephalopathy and uremic pericarditis. And what they are is the urea builds up in the blood, and then you can get those complications. Simple as that. I've not gone into any detail on them because it would just be beyond the point of the talk. Another complication is pulmonary edema. So obviously, if your kidneys aren't filtering properly, or if your heart failure is the cause of your AKI, then you might have pulmonary edema. Basic management for that: sit them upright because it helps them to breathe. High flow oxygen. Furosemide is a loop diuretic that'll help basically for them to get rid of some of the fluids, because that is pulmonary edema, is fluid overload and basically water on the lungs. CPAP can be used to help them breathe, and then you can also go into dialysis and nitrates. Keep going. So general management of AKI, IV fluids. You want, especially for a pre-renal cause, you want to get that blood pressure up, and you want to get them to perfuse in the kidneys. Monitor their urine output. This doesn't necessarily have to be a catheter, because it might be overkill giving every single person a catheter, and introducing infection and stuff like that. But if they're going to ITU, they probably will be having a catheter, and if they're really unwell, something to think about. Post-renal causes, said before, think about an ultrasound scan if you're thinking about it. Another important management step for the AKI, as I said, with the drug history, make sure that you're looking at what could be a nephrotoxic drug or drugs that are contraindicated in renal failure or renal impairment. I've put some examples there of drugs that are renally cleared. So as you can imagine, if you didn't stop these and they had an AKI, you might get a buildup of digoxin and give them a heart block, or build up of metformin, again, lactic acidosis, build up of lithium, you can get serotonin syndrome or just toxicity. And then obviously monitor their use and these regularly, and treat the cause. I've not gone into treating every cause, because the management for each different one would be different. So, pre-renal causes, renal causes, post-renal, they're all different. So, for example, a post-renal cause, if they got a stone, it might be the case that you have to give them a nephrostomy to drain the urine, or you have to go and surgically take the stone out. So I've put in here some investigations to consider. I don't think I'm going to go into details of this slide, actually, because it's a bit over the top. But if you're waking someone up, think about tests in this way, especially for your OSCEs: bedside bloods, and then imaging or other, and do it in this order, because a urinalysis and an ECG is easy to do. And then obviously, if you're getting down to imaging, you should be thinking at that point, right, so my differential diagnosis is a post-renal cause. I want an ultrasound scan, or I want a CT kidney urethra bladder to rule out a kidney stone. And then obviously some of those bloods in there, like the autoantibodies, that would be very much if you were thinking about glomerulonephritis and stuff like that. I've put in this slide on indications for dialysis. Again, I don't think it's a necessity to learn all of them. However, they are just the complications of AKI. So really bad hyperkalemia, pulmonary edema, metabolic acidosis, uremia, and then toxins or drug overdose. So basically the refractory means as well that it's not getting better with treatment. But so they're just the complications, really. I've put in some more MCQs now. I'll give people time to have a little read, and then so this is coming towards the end here. So these are probably kind of similar to what you get in your exam that I made up off the top of my head, and hopefully they'll highlight some key points.
So someone in the chat's put C. Yep,
fab. So again, this lady has fallen, and she got a long lie time. So she's fallen on her hip. She's been on the floor all night, and that's right. So the diagnosis is rhabdomyolysis, and the blood test that would help confirm that is creatinine kinase. And again, I've put in a little box about what rhabdomyolysis is. So basically, it commonly happens in like a crush injury, or if someone's fallen, like especially an old person's fallen and been on the floor for 2 days, and the basic muscle starts to break down and releases some of the substrates in it. CK can be good to help diagnose it, and then you'd get like cola or tea colored urine, and the management I've put there at the bottom. Next one, male patient complaining of polyuria, tiredness, fierce lower back pain. Admitting doctor performs some investigations, and a couple of the abnormal results are a raised creatinine, raised calcium, and a raised ESR. Given the most likely diagnosis, what investigation should be performed next? So again,
sorry, Oscar just had there was a quick question about that last MCQ.
Yeah.
Is that a renal AKI, the rhabdomyolysis?
Yeah, it is. It is a renal AKI. So basically, what happens is the myoglobin basically all gets stuck in the kidneys, and yeah, so it's a renal cause. It's gets stuck in the tubules basically, and I don't know how to describe it. I was going to say mucks it up, but that's not a very very good way to describe it. But yeah, it's a renal cause, that one. So yeah, any answers for this one? Again, in the exam, they might put in more results, more investigation results to try and confuse you, but I've only put the key ones in here to try and get out a specific diagnosis.
So someone said B.
B. Okay, I get why they've gone for B, because polyuria and tiredness and thirst are all like hallmarks of diabetes, aren't they? But actually, specifically look at some of the blood results. You've got a raised calcium and a raised ESR.
They said they're having second thoughts, so I think we might have another answer coming.
Yeah.
They're not sure.
Not sure. That's okay. It's quite this one. I think we had one similar to this about. So basically, the diagnosis is myeloma, and the answer then is serum electrophoresis. So the hallmarks of myeloma is raised calcium, renal failure, so an AKI, anemia, and bone pain. So this person's got back pain, polyuria, tiredness, thirst, and a raised calcium. So he's got almost all the features. And basically then the key investigations of that are an FBC, a Usinase, a calcium, an ESR, a urine Benz-Jones protein, and a serum electrophoresis. So they'll often give in the exam questions that they try and lead you to a diagnosis and then ask you what's the investigation to confirm it, or they'll give you like urine Benz-Jones proteins is raised, and on electrophoresis there's monoclonal bands and stuff like that, and try and get you to put myeloma. But again, they will put distractors in, for example, the polyuria and tiredness, yeah, HbA1c, because it could be diabetes, but actually no, the person's got a raised calcium and a raised ESR, so myeloma is the correct diagnosis. Is that okay?
Yeah, that's great.
And yeah, the way to remember it is CRAB, if acronyms help people. 35-year-old lady, history of recurrent miscarriages, presents to a GP complaining of joint pain, fever, oral ulcers, and +3 protein on urine dip. What's the most likely diagnosis? Give people a second to have a think. Okay, so the correct answer for this one is SLE. Okay, so what I was getting at here is basically that this lady's got lupus nephritis. Okay, so this will be a bit easier to explain now. So recurrent miscarriages are associated with antiphospholipid syndrome, which lots of people with SLE have. Joint pain, fever, oral ulcers, and +3 protein is all. So the +3 protein is getting at there's a renal involvement. So lupus nephritis, and then oral ulcers, fever, and joint pain are all hallmarks of SLE. SLE is one of those conditions that can affect basically almost anything. So in a young, particularly women, recurrent miscarriages bit here I think helps quite a lot. But a young woman with, you know, like non-specific kind of symptoms, or like, you know, different systems over different symptoms over different body systems, can be quite quite a good question to throw into the exam, especially if you've got like rheumatology in your 4th year. Important antibodies for it is ANA, anti-nuclear antibody, and anti-DSA, anti-double-stranded DNA antibody. Fab. So last MCQ, 78-year-old lady undergoing chemotherapy. She went to A&E with an arrhythmia. She began her first cycle of chemotherapy 3 days ago. What drug is sometimes prescribed to patients undergoing chemotherapy to prevent the complication that has occurred in this lady? So again, firstly, what do you think the diagnosis is? Secondly, what is the treatment? So again, they're not just going to ask you questions that are, oh, so what's the diagnosis? They're going to ask you about a specific subset of the management of that condition.
So someone said B as an answer to the question.
Yep, that's correct. So this lady has got tumorlysis syndrome. So that often occurs when someone has got, usually it's like a blood cancer, so like a leukemia or a lymphoma, and you give the chemotherapy and it basically causes the tumor to die, and all the cells then release all those things, the potassium, urate, phosphates, and then you get hyperkalemia basically. So that's where the arrhythmias and the renal failures coming from. And actually, yeah, that's right. Allopurinol is often given with the chemotherapy to prevent this complication happening. Again, this is a renal cause of an AKI. So all those things that are getting released there. So particularly the urate causes a hyperuricemia. I can't even say that. Basically, a renal nephropathy caused by the increased urate. So I put in this one at the end. I don't know if people are still with, but I'll leave it up for a second and then I'll talk through it. Particularly because I couldn't do a whole session on glomerulonephritis. I thought I'd put in some of the causes and how you differentiate between them in an MCQ. So I'll give people a minute or so if you want to pause it here, if you're watching again, and then I'll have a little talk through some of the answers, okay?
We've had an answer through for number 1.
Mm-hmm.
Someone said H for number 1.
Okay, we'll wait a little bit longer. Have a little think about all of them and what you think they'd be, and then what I'll do is I'll put the answers up and I'll talk through each one individually. So glomerulonephritis is one of those ones where there's like one lecture on it or something ridiculous, and if you'd never get a question like this with all of them, but there's key little, basically one word in the question that'll turn from one diagnosis to the other. Have a think about 2, 3, 4, and 5 as well, guys. Maybe just jot down some thoughts about what you think the diagnosis is. And then what I'll do is I'll start talking through them. So yeah, 2, Kate, Scott. Give a little bit more time just because obviously if you ever had an MCQ like this, it's 5 questions, you'd have a lot of time to do it. Right, we'll start with 1 then, and I'll pause for the other ones. Hold on. Right. So yeah, 1's B. I think someone got that right in the chat. So frank hematuria, cough 2 days ago. On further questioning, admits he's got a respiratory tract infection. Because I think someone just said it, 2 of them are basically very hard to choose which way around. I won't go into that one until I get to number 3 because it's basically 2 answers the other way around. There's one key bit in this question that gives it away, is the anti-glomerular basement membrane antibody. and that specifically is for Goodpasture syndrome. And so patients with Goodpastures will get hemoptysis, and then obviously again with glomerulonephritis, you can either have nephrotic or nephritic kind of pictures. So you get things like protein or hematuria. So yeah, the anti-GBM is the giveaway for that one. The next one is post-streptococcal glomerulonephritis. So these two, post-streptococcal and IgA nephropathy, are very, very similar. So they present with hematuria, but the key thing about it is the length of time away from the illness. So in a post-streptococcal glomerulonephritis, think of it as like almost a couple of weeks later. And also a textbook thing is colored urine and red cell casts on microscopy. So they'll have a throat infection, which will basically get better, or they'll have a strep throat. It'll get better on its own. And then they'll end up with hematuria a couple of weeks later. And it tends to be kids, although it can be older. And then obviously then with one is IgA nephropathy. It's more acute, it's more sudden. Again, these are not hard and fast rules, but the best way to distinguish between them is post-streptococcal is slightly longer, IgA nephropathy is a bit more acute, okay? Number 4 is minimal change disease. So minimal change is the most common nephrotic syndrome in children. And so with nephrotic, you get protein and swelling and hypoalbuminemia and stuff. So that's minimal change is always a good answer. If you think it's a nephrotic in children, always think minimal change. And then the last one, tiredness, joint pain, malar rash, which are all key symptoms of a thing we spoke about earlier, which is lupus nephritis. So again, malar rash, joint pain, tiredness, anti-nuclear positive and double-strand DNA positive. So I'm getting at lupus nephritis. The condition she has a 33% chance of developing, of course, is lupus nephritis. Yeah. So basically, just because someone has SLE doesn't necessarily mean they'll get lupus nephritis, but again, there is a chance. Okay, that's everything. Thanks to those of you who came. Has anyone got any questions or any comments or anything? Hopefully, some of these MCQs have highlighted some key points. And just to finish off, AKI is not a particularly challenging one to learn for finals, but it is an important one. Make sure you can stage them. Make sure you know a couple of courses for pre-renal, renal, and post-renal AKIs. And then make sure you know about the basic management. And then if I was you, I'd know hyperkalemia pretty well. And if you can cover those bases, then you'll always know a little bit about it. You don't need to go mad and learn every little thing, but if you can know them, I think you'll be doing all right. And to be fair, well done to those of you who came tonight, because it's quite far from exams, so you've done quite well.